Welcome to the On Becoming a Healer podcast. I'm Stefan Kertes. My co-host is Saul Weiner. Hi, Saul.
Hi, Stefan.
So today's episode, we're going to be talking about professionalism. We'll be hearing from two thoughtful and well-informed guests. This topic was your idea, Saul. Tell me how you got interested in an episode on professionalism.
Well, it came as a result of serving on my own medical school's Medical Student Professionalism Committee. As I think many of our listeners know, I've had concerns about the culture of medical training. And the culture is certainly central to how we remediate behaviors that fall short of what we'd like to see in a budding medical professional. Now, while I do think that the mission of helping medical students be more professional is critical, I have concerns about the way we're going about it. And I think that some of what we do may in fact be counterproductive. And it was with that thought in mind that I started looking at the literature and discovered the work of one of our guests, and then she in turn led me to the second guest, who we'll be hearing from as well today.
So let me just underscore a theme I know is going to come out of the interviews, which are pre-recorded. One part of medical training is offering correction and remediation. And I think in your view, and maybe mine too, that remediation, that fixing is part of how our medical training system does worse than it should. But that's not the only thing we're concerned about here, is it, Saul?
Well, at least in my view, our profession isn't doing a very good job at being professional. For instance, there's ample evidence of abuse and harassment just during training. I found some shocking data, and I think we should devote another episode just to this, on the level of reported mistreatment by residents and attendings as seen through the eyes of medical students. Somewhere around 60% of medical students report mistreatment, and that ranges from gender and racial discrimination to physical intimidation, and especially to public humiliation at some point in time in their training by residents or attendings. Now, what that suggests to me is that there's a kind of dysfunctional family environment within the medical training setting. And that's because, of course, these medical students themselves become residents and then subsequently attendings. And some of them perpetuate the abuse.
So, okay, I hear dysfunctional family environment. I realize I don't like it. But do you or I think any of that is affecting patient care?
I do. There's substantial evidence, in fact, that patients are not very happy with the experiences they're having with many physicians. And they're talking about it. For instance, I recently came across an opinion piece in USA Today from a patient advocate that was titled, "My Doctor Made Me Cry. It summed up everything that's wrong with healthcare." And her essay included the following.
Okay.
She wrote, "As a new resident of Fort Myers, Florida, I was trying to establish a relationship with a local primary care physician. From the start, the doctor's focus was on her computer, not me. She stared at a screen while I stared off into space. She challenged me on why I had an inhaler prescribed by a previous doctor. I explained that hay fever leaves me short of breath. But her screen said I needed an asthma diagnosis, which I don't have. Then she asked me why my blood pressure was so high, a first for me. Bewildered, I said I had ended a lifelong friendship the night before. Sidetracked again. It turns out there's no software code for that. I needed a dose of kindness and some clinical insight. I got clicking and keystrokes instead."
Well, that sounds familiar. This writer's having a terrible care experience because she has the audacity to, wait for it, not fit into a box in the electronic medical bureaucracy that we live in. Well, count me as not surprised, and on her behalf, ticked off.
I agree, although rather than being outraged, I think this account mostly just makes me feel sad. The sense I have is that a physician who's behaving that way is probably burned out and has either lost or never acquired the capacity to engage. There's probably no nourishment that she's gaining from the human interaction she's having. And it leaves me wondering about how she was shaped by her training experience and how that brought her to this point.
Yeah, I agree with that. We've talked previously about how there's something about the culture of how we train physicians that can turn us into sort of zombie doctors. Cue the ominous music. You use this word that we become efficient task completers, and we don't or we can't connect with our patients. But just to circle this back to professionalism, is that zombie doctor behavior, is that connected to how we teach Professionalism?
Well, we'll hear from our guests about that. My concern is that the way we try to remediate professionalism issues is so bureaucratic. For instance, the committee on which I serve reviews forms that are sent to us by administrators who have heard or seen concerning behavior by medical students. The most common category is unreliability. That includes not responding to multiple emails requesting that students complete compliance requirements, or turn in assignments, or delays in responding to requests for meetings.
Wait, is there a medical student who screws up on email?
Believe it or not, it's been known to happen. And of course, none of us do. Anyway, there's also the more serious allegation that we hear from time to time, such as plagiarism. Our job is to determine if these infractions are serious enough to kick up to a higher level committee where the repercussions could be more severe, or simply to file them and recommend some sort of remediation. We who make these decisions often don't know these students, haven't met them, and have only a few minutes to figure out what to do.
Okay, so I can see how this very top-down assessment could feel pretty heavy-handed from a student's point of view, and it could even maybe make them more cynical and less engaged. So maybe the final part of this is, how does it make you feel?
I'm often left wondering what might be going on in the lives of these individuals. I mean, what kind of pain or isolation or even loneliness might they be experiencing? And are our attempts to improve professionalism as a committee productive or not productive? What I think needs to be there that is missing is more engagement. People learn and grow through relationships. They grow through feeling cared about and through interactions that occur on a level playing field where they feel safe. And unfortunately, that is often all too uncommon during medical training. And that's because of our unforgiving and, in my opinion, judgmental culture.
Okay, so let's hear now from these two thoughtful individuals. And I should say, before we get started, I mentioned this before, the two interviews happened on different days. Saul did one of the interviews, the one with Dr. Deborah Zuring, because I wasn't available. And I did most of the interview with Dr. John Spandorfer. So I'll start by introducing John and then immediately ask him to define professionalism. And because I think it's important to start by talking about what that term means, let's begin by listening to just that right now. I have a real pleasure that we have as a guest John Spandorfer. Dr. John Spandorfer is the Roger Daniels Associate Dean for Professionalism in Medicine and Professor of Medicine at Sidney Kimmel Medical College at Jefferson University in Philadelphia. He has made professionalism a major focus. He is the co-editor for a text, Professionalism in Medicine, a case-based guide for medical students. He's also the co-editor of the newly performed professionalformation.org and has published a number of articles on this, and obviously it's part of his professional work. So welcome, John. I'm so happy to have you.
Stefan, thank you very much for having me. I'm really looking forward to this.
So I wanted to start by just asking you, John, how would you define professionalism in medicine?
But when I first speak with the first year students, I attempt to do that. And I keep it somewhat simple. There's a number of components. First and foremost, it's competency. There's probably nothing more important. And our trainees rapidly gain competence. I think secondly, adherence to ethical principles. And we talk about that, and that gets incorporated into a lot of our case-based learning. Third, there's, this sort of nebulous, what's the conduct of a physician? There's a certain conduct that's expected. And if there's some deviation of that, we're considered to be unprofessional. Next, there's a sense that the patient's interest has to come first. There needs to be this sense of altruism or selflessness. And then finally, and this is really true of not just medicine, but really any profession where you think of professionalism, that is, there needs to be some sort of regulation, some self-regulation or regulation of the profession, where members of that profession need to be able to speak up and work on peers to try to improve the profession in general. And of course, there's been cases when there's not that self-regulation, then there's unfortunately external regulation.
So I heard there competency, adherence to certain principles, the right conduct in relation to those principles, putting the patient first, and the ability to self-regulate or to correct when we make errors. Did I get it there?
Yes. Yeah.
Why have you decided you care about this right now?
Well, I've had this academic experience whereby I had the chance to work on a course on doctoring for a number of years for our preclinical students. I was a student affairs dean for a number of years. I saw some of the effects of student mistreatment and the hidden curriculum on our students. And at my institution a number of years ago, we showed an article titled "The Devils in the Third Year: An Erosion of Empathy," where the Jefferson Empathy Scale was employed and empathy dropped as students went from year 2 to year 3. So I got interested in this topic of professionalism with that lens and trying to make a difference. And that's what I've tried to do. I've taken on this role at my medical school 12 years ago. And you need to be patient. You need to be, when you work on these things, you need to be an incrementalist and to try to tackle on different projects. So that's where my interest came from, all the background in medical education and seeing some of the trouble out there with professionalism.
Yeah, I want to draw that out because I think that there are things that happen in that third year or fourth year where you suddenly feel, oh my God, what's going on here? I remember some anger from a surgical resident, and he threw his instrument at me in the OR in a kind of careless way. I don't think he was trying to hit me exactly, but he was just being kind of snappy. And the instrument penetrated my glove and caused me to bleed. And at that time, there was a lot of concern about HIV transmission in the OR, et cetera. And as I recall, I didn't feel I could speak to the resident about that. I had just sort of incurred an injury with some fear of acquiring an infectious disease. And I wound up speaking with someone in administration, and then we kind of handled it. But it felt like an insult and an odd, strange moment. And I'm wondering if you've seen moments like that, which kind of motivated you to be concerned.
Yeah, I mean, not to overly focus on surgeons, but I had a similar experience as a medical student with a surgical attending who had a real violent streak and was throwing instruments and berated residents and the nurses. Less so myself. I didn't feel victimized by him, but there were other encounters where I felt, I'd say, publicly humiliated. And by the way, public humiliation is the most common form of student mistreatment as reported on the AAMC surveys nationally and at my own institution. And that those who publicly humiliated me were from multiple specialties, not just surgery. So I had those personal experiences as a student affairs dean. I had students come to me talking about that, not only being hesitant to speak up at the time, but being hesitant to speak up ever and coming to me much later and hearing about this. And in my current role, I hear students coming to me months later. I just had a student who came to me with an experience that she had, and it was over a year ago, and she just gone through the match and didn't want to say anything until her residency spot was secured. So these things happen at every institution. Unfortunately, the culture of medicine is such that for many reasons, people higher up in the hierarchy, be it attendings or residents, may, for reasons where they're burned out or they have problems that aren't being addressed and they're tense and things go wrong in the clinical environment, that they lash out, and that happens. And look, it happens not just in medicine; it happens in all professions. But in medicine, there's sometimes dire consequences around the student's education, the sort of physician that the student will become, and of course, safety too, right? So it's when people feel like they can't speak up because they're humiliated, they're intimidated, they're harassed, they're less likely to speak up, and that can impact patient safety.
Our second guest, Dr. Deborah Zuring, is currently the Senior Associate Dean, Undergraduate Medical Education and Academic Affairs at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. And as I mentioned, she had pointed me to John. Both of them are at the same institution. One of the things that I found particularly helpful about talking with each of them is that their perspectives are complementary. John focuses on the issue of professionalism at a system-wide level. He's interested in addressing the challenge of enhancing professionalism across the entire ecosystem, from medical students to residents to faculty to the entire culture and environment where the physicians at his medical school teach and take care of patients. Deborah, in contrast, is focused on undergraduate medical education, the education of medical students, and actually her priority in recent years has been on the curriculum rather than on professionalism per se. although before coming to Jefferson at another medical school, she focused on issues of professionalism, not just as a practitioner, but as a scholar. And as I said, I was drawn to her work after seeing one of her publications titled How do Medical Schools Identify and Remediate Professionalism Lapses in Medical Students? A Study of U.S. and Canadian Medical Schools. So early in the interview, I asked Deborah to talk briefly about the study and what they found.
So at the time, there were 153 medical schools in the US and Canada, and they were all invited to participate in this study. We actually got responses from 93 of them, so about 60% of the schools participated. And those were semi-structured interviews, which gave us a chance to actually have a dialogue about what they were doing, in addition to some standard questions that we asked of everyone. I would say the largest take-home was an incredible variability between the schools in how they were doing things with regard to different levels of lapses, the systems that were in place, the individuals who were involved. And there was just this probably very high degree of unwanted variability that was actually in the system at the time.
Now, given the concerns that I shared in my introduction, based on data coming from the experience of residents and the way they're treated by attending physicians, the experiences of patients, obviously we have a professionalism problem. And the question is whether the efforts we're making in medical education are the right ones. And one of the challenges seems to be that we don't have a lot of data on whether our remediation efforts are working. And I'm curious if you can comment on that.
Yeah, that's the crux of the problem, isn't it? Because you need longitudinal follow-up, you need sufficient numbers to determine that those are actually valid data sets, and you need a lot of cooperation along the way between the undergraduate med ed, the graduate, continuing practice, state medical boards, in order to really determine what's working. And I think the other issue is that the majority of people who have professionalism lapses in medical school don't go on to have major lapses and citations by their state medical boards. It's just a tiny fraction. So it's difficult to ascertain cause and effect as far as whether the remediation worked.
As I later reflected on this part of the conversation, it occurred to me that not only do we not know if our attempts to remediate potential lapses in professionalism are effective, we also don't know whether we might be potentially causing harm with our interventions. And this has been an issue for me as a faculty member when I've sometimes been reluctant to take formal action around something that I consider to be relatively minor and to just try to deal with it myself. I'm thinking in particular at the moment of a former resident in this case, where there were some issues in terms of his interactions with nurses that suggested he could at times be a little harsh or bullying. And I took him to lunch and had a long conversation with him about it. Nothing went on the record. And it really was amazingly effective. From then on, he did very, very well. And I was pretty careful to check up on things. And so I think that the question of taking formal steps and the concern about the implications of doing that are ones that may have crossed the minds of some of my colleagues as well. Deborah actually looked at this in a study that she published with colleagues in 2015 called Silent Witnesses, a faculty reluctance to report medical students' professionalism lapses. And in that study, they collected qualitative data from 184 attending physicians. And when I asked her what she found, she shared the following.
Part of the reason they don't report is they don't know whether the behavior that they witness on one occasion is part of a pattern of behavior. And obviously, professionalism lapses are, dynamic and contextual, and you need to understand patterns of behavior of that individual to determine whether or not an approach is really necessary for long-term monitoring and remediation. And so I say that because there is a tendency in medical training to have a lot of movement of interactions of faculty and students that they don't have a longitudinal relationship. And so it's very difficult for faculty to know whether it's a pattern and to be comfortable discussing with the student whatever happened and what the ramifications are. Faculty often don't even know what happens if they report a student for a professionalism lapse and how big a black mark it will be, if you will, on the student's record and their ability to match and so on.
I have to say, speaking as a faculty member who has sometimes been hesitant to report things that I've been concerned about with a student because I'm afraid that it could get blown out of proportion, what I sometimes do is I will just talk to the student myself, and I'll make it very clear to them that I'm not going to report them and that this is just me wanting to have a helpful conversation with them. And I find that sometimes when I make it and I'm very explicit, like, this isn't going anywhere. I just want you to know what my concerns are so we can talk about it. And I find that sometimes liberates the student to be more open themselves, knowing that nothing they say is going to be held against them.
It's a bit similar. I don't know if you're familiar with Jerry Hickson's work out of Vanderbilt in this realm, largely around faculty. But he starts the pyramid of responses with a cup of coffee conversation. And it's just a cup of coffee and a conversation about what's going on.
Deborah's reference to cup of coffee conversations really resonated with me and got me to thinking, what can we do to foster a culture within medical schools where there are more cup of coffee conversations and fewer instances in which committees are tracking and monitoring medical students and remediating them in a somewhat cold and dispassionate context? One approach that Deborah talked about is simply creating more longitudinal relationships between students and faculty in the curriculum. This came up when I asked her how we can avoid situations in which students are being assessed by a committee that doesn't really know them or by a faculty member who has seen something potentially concerning once but doesn't know how to put it into a broader context because they don't really know the student. And it turned out that this was something that she and her committee had been thinking about when they redesigned their curriculum.
One of the ways that we really wanted to get around that with our curricular change was to foster small group interactions with a faculty member over a period of continuity. And so, for example, in our pre-clerkship phase, students spend 12 weeks in a small group of 10 students with one faculty member for 4 hours a week. That's a lot of contact time. And built into that are periodic feedback cycles where the faculty member talks to the student about how they're doing. And that's not just with lapses, but it might have to do with their dominance in the group and not allowing other people to speak up. Or it might be that they came to late 4 times and having a conversation about why that's going on. But the fact that it's occurring within a relationship and one that you can follow up, whether there's a change in that behavior, makes it a much more robust way to get students to listen to that feedback and to understand the impact of their behavior on others, rather than much more anonymous situation in the clinical environment where they might be with an attending for just a day or just a week.
One of the themes that Deborah and I talked about quite a bit is mutual respect. On the one hand, there's a tendency of medical school faculty and the culture generally to infantilize students, to treat them as being younger and less mature than they actually are. And this can be degrading, and it doesn't necessarily bring out the best in students. I think that when you're struggling as a student, it is easy to look like a fool, to look like you're disorganized and unresponsive, when in fact you're simply overwhelmed. And it's easy for faculty who may be years out of residency to forget what it's like to be in that experience. At the same time, medical students can be harsh and judgmental towards faculty in ways that are also not respectful. And so I thought Deborah had some interesting suggestions and a general approach to dealing with that side of the coin as well.
Yeah, I think it brings us back to what you said earlier about mutual respect and trust. It's really a two-way street, and we need to treat students that way, and they need to be respectful and treat us in the same manner. And it does work both ways. We get feedback about some of our lecturers and their coursework, and it's not respectful. It might be about, their language barriers. It might be about the tie they had on, but it's not respectful in constructing a better way for them to do the lecture so that perhaps it's more understandable. And so I think one of the things that I've done is come back to the class and actually show them examples of some of this feedback that we've gotten that's incredibly constructive and helpful, and some that really is disrespectful to the lecturer and has no constructive content in it. But I think this whole idea of mutual respect and trust is at the core of what you're describing.
I really liked the exercise that Dr. Zuring described, in which she went and showed the medical students both the respectful and really disrespectful feedback that they were giving to some of the faculty. And one of the reasons I liked it is that these students are soon going to become residents, and then they're going to become attendings. And hopefully they will remember that lesson when they're in positions of much greater power about how to be kind and thoughtful rather than to just be reactive when you see something that you don't like in the behavior of somebody else. And another great example of really constructive and potentially life-changing feedback came from a program that Dr. Spandorfer described, in which medical students essentially evaluate their attendings on the basis of the extent to which their attendings are respectful towards them and towards others who they observe, and how this program, which has only been in effect for around 5 years, has been quite transformative. John began by describing how he first learned about the program and introduced it to his institution.
I was inspired by an article that appeared in Academic Medicine out of UCLA, where they described their many year history in trying to tackle the problem of student mistreatment. So they used this metric where they asked students after each rotation whether they were treated with respect and whether they observed the individuals they worked with treat others with respect. So we use these respect questions, and after each rotation, the students are expected to rate faculty and house staff that they work with. There's no prescribed number. They could rate 2. We estimate at least 2. They could rate 10. And it's on a 5-point Likert scale. 5 is great, 1 is bad. And then along with that, if they giving them a lower score, to offer some comments as to what happened, so we could try to correlate the problem. It's all blinded. No one except me knows who the students are, and I don't really look to find out. That's not important to me. And what we do is after all the year's rotations, we aggregate the score. And as an aside, we not only do these respect questions, but we have a number of questions that relate to teaching effectiveness, which aren't specifically professionalism related questions. So house staff, faculty get a respect score. And the average scores are great. I mean, they're nearly 5 in each department. But we have standard deviations, looking for outliers. And there's standard deviations depending on the department, maybe 0.25 up to 0.5. So they can vary, and we can see where outliers are. So we've started this 5 years ago. So we just completed we're just about to complete our 5th year. So and each year we have over 10,000 individual responses. Again, we have a large class, nearly 280 students. So over 10,000 evaluations per year. And so this is used as a positive and a negative. So I really like to focus first on the positive. So attendings and residents work hard. Again, we talked about burnout before. This is a way for attendings and residents to see how much they're appreciated. And we even have, our top folks who get the best scores. We have a clinical education honor roll. You have to have a score of 4.75 out of 5 for respect and the teaching effectiveness, and at least 5 ratings. And we heavily promote this. We have it on our plasma screens. We have posters that are in a lot of our buildings up for the whole year with everyone's name on there at Jefferson. And we have some wonderful affiliates, and we ask them to do the same thing at their hospitals. So we really promote that. This is used for promotions, and so that's the big positive, because overwhelmingly these are really good scores. All right, but some people get low scores. Here's the good news. Feedback works. And I'll tell you what we just found. So the first 4 years of doing this, there were 250 individuals who got at least one score of a 1 or 2 out of this 5-point Likert scale. Of those 250, virtually all of them did not appear this last year. as a low score. So only 8 of those 250, what is that, like 0.3% or so, came up as a low score this last academic year, which we're just about to finish. Now, okay, some of those people left. They may have been residents who left, and maybe some attendings left, but 95+% of them are still here, and they saw the feedback and they improved. So that's the power of feedback, and I let the students know that. I spoke to the rising fourth year class the other day, and I told them that. And they have to understand they're not just wasting their time with another survey, right? We give our students surveys all the time. There's survey fatigue. This is a really powerful survey, and I'm not trying to minimize the importance of all these other surveys, but I let them know how powerful this is. Both on a positive side, this helps physician wellness, seeing not only these scores but the comments that come along with it. And, we're not trying to punish anyone who get low scores. We're just trying to show it to them. And we have, cup of coffee conversations with, if it's a resident, it's the program director. If it's a faculty member, it may be the chair or clerkship director. Cup of coffee. We're not trying to harm anyone. No punishment. We're just trying to, no one comes to work saying, I want to mistreat a student or not show them respect. But this is how you're being perceived, and try to change. And they usually do. And we know this from other types of feedback. The work that Hicks and others have done at Vanderbilt with peer-to-peer feedback. It works. It works. And that's with disruptive physicians.
One of the elephants in the room when we have these discussions about the professionalism exhibited by attending physicians, residents, medical students, is the larger milieu, meaning the actual systems issues in which they're having to function. Just as I talked about how medical school can perhaps bring out the worst in people under enormous stress, and in a culture that is sometimes negative or demeaning. Similarly, attendings can essentially behave badly in environments where they feel beaten down and unappreciated. And this was something that Stefan asked about.
Is there a way in which interpersonal respect falls apart when you're in a system that's kind of messed up?
Absolutely. Look, these primary care docs who are working so hard and not given, respect and just told by the accountants to, get more RVUs. There's been so much written on physician wellness and what can be done to improve all of our day-to-day lives. And if you don't work on that, the students are going to go into a culture that's toxic. They're going to learn this is how it is. They're going to mistreat the future students. It's never going to change. So it's not just the first day telling a medical student about professionalism and all the do's and don'ts and making sure they're being followed closely and bringing them into our judicial board for problems. It's the whole system. It's all tied together. And it's not just tied together in one system, right? We cross-pollinate each other. So we have residents from your institution that come to our institution. We have attendings who move around. So, it's a national problem that we need to work on.
On the one hand, I find myself very sympathetic to this perspective. After all, how humans function and behave is context dependent. So if you're in a dysfunctional environment, that's going to have an effect on how you interact with your colleagues. And yet, one could say that a true measure of character is how people behave when things are not copacetic. When, for instance, you're on an airplane that's overcrowded and people are bumping up against each other. Are you one of those individuals who loses their cool and starts yelling at the flight attendant and waving your bags around? Or are you the one who remains calm, who remains civil? And to some extent, at least in my view, professionalism is about being the latter. So while there is absolutely no doubt that we need to do something about the environment in which physicians practice, which is contributing to burnout, we also have to be mindful of what the expectations are from a professionalism standpoint under conditions of stress. No matter how busy or dysfunctional the OR or the inpatient unit or the clinic, it's never okay to yell at the medical student or nurse or anyone. This is a point of view that I think both of our guests endorsed, and I asked Deborah about it directly.
Well, I think the dialogue in some areas has switched to this concept of civility, right? And just treating each other with normal day-to-day civility and supporting a culture, again, that promotes civility rather than tolerates the incivilities that creep into the day-to-day interactions and have a very negative effect on almost everybody that experiences them.
I think that both Deborah and John conveyed that fostering civility and enhancing professionalism in the community can't be a heavy-handed process. It really is about relationships and about creating an open and trusting environment where all of us, medical students, residents, attending physicians, can improve together. As I mentioned earlier, I have concerns about a strategy that's employed at my own institution and at many others based on Deb's research, in which students are written up for relatively minor breaches like falling behind on email reminders and not completing compliance requirements, essential to starting clerkships or things like that, where I would favor a consequences-based approach so that they simply learn that if you don't do this stuff, there are consequences and you won't be able to do your rotations on time. And that has significant downstream effects, and so forth. Those are instances where I think a cup of coffee conversation is probably what's needed to find out what the heck is going on with this person that they become so unreliable. John seemed to concur with my perspective when I asked him what he thought.
Yeah, no, I would be very hesitant about bringing a student for a relatively low level infraction like not emailing correctly or missing a deadline for an assignment to bring them before a professionalism committee. We just wouldn't do that. We do have a similar committee, and it's rare that we do bring a student up. And it's things that are much more serious than that, that you start to think maybe this person shouldn't be a physician. So it's rare. But I agree with Deb, the cup of coffee conversation, bring them in. Let's just talk about what happened. No one's perfect. This is a part of your professional growth. This is sort of what we expect, and also right along with that, what we have a student affairs dean who act as an advocate for the student. What's going on? Is there something that we should know about to help you? And it's often the case that there's some distraction going on, maybe a family illness, maybe their own illness. We look at this as being just a formative process, almost always. Med school is 4 years. When they trip up early, we still have a lot of time to watch them. And it's very rare that we see a pattern of this. What I see in my role is not really so much lapses on the student, and I see lapses on the instructors, the residents, and that's far more common.
I think John's final point there is important to take note of, which is we're more of a problem. We the instructors, are more of a problem than the students are. Now, that doesn't mean we should be disregarding issues of professionalism with the students, but we need to be doing it with a high level of humility. If our behaviors got written up and sent to committee as readily as what occurs with students, certainly at my institution, and again, I think at quite a few others, most of us would be in big trouble. Speaking personally, for instance, I'm constantly falling behind on all of the compliance modules that I need to be doing for various clinical requirements. My view is that we need to start from the premise that being a doctor and a medical student before that is really hard, and that the people who get into medical school are almost overwhelmingly highly conscientious and desirous of doing the right thing. What works best with highly motivated people, I think, is to be supportive of them and to show them kindness. And then when it comes to be their turn to have power and to mentor, they are more likely to pay it forward. I like the way Deborah put it.
At the end of the day, it's about a supportive culture rather than a punitive culture, and helping to support the student, understanding why they're exhibiting a behavior. Maybe they're struggling with some personal issues and are having trouble getting to the class on time. As you said, the realm that most people lapse in has to do with this domain of responsibility. And so it is all of those subtle things that people fail to deliver on, if you will, that they said they would, whether that's arriving on time or completing, epic charting or all the other things that happen that physicians drop the ball on sometimes because of competing responsibilities. And you're right, students see that. And if you make it all or none, then nobody measures up, right? But I think that if we help them do it more often than not, which is what we expect of our faculty, that's a reasonable and supportive way to approach it.
So there you have it. I'd like to end with a personal anecdote. A number of years ago, I was the Senior Associate Dean of Educational Affairs at my medical school, where I had administrative oversight of the medical school curriculum across multiple campuses and also the residency and fellowship programs. A couple of half days each week, I would take a break from all of that and head over to the clinics to supervise the residents. Oftentimes, my meetings would run over and I would show up late for clinic. This wasn't fair to the residents and it wasn't fair to their patients. Somehow I rationalized it, perhaps because I thought I was so important. In any event, the residency program director contacted me and shared with me that he had heard that I was showing up late for clinic and asked me if I could fix it. I felt quite mortified because I realized he was absolutely right. And if anyone should be setting an example, that would be me. I was never late for clinic again. That was the kind of feedback on my professionalism that I deeply appreciated. And I was grateful to this program director's courage in reaching out to me and giving me what was essentially a nudge. So that's what I hope we can do for each other, up and down the hierarchy, up and down the chain of command. Well, thank you all for listening to this episode, and I'd like to close by expressing my and Stefan's deepest appreciation to John Spandorfer and Deborah Zuring for sharing their tremendous experience and insight into such an important topic, and doing so through a lens of deep humanity. So thank you all for listening and giving this podcast some of your time. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.